Hello, and welcome to Epstein Becker Green's Telehealth Crash Course series. Today's crash course is the first of 3 sessions entitled Understanding the Federal and State Landscape for Prescribing via Telehealth. Before we begin today's presentation, please be informed that today's webinar is being recorded and the participant phone lines will be placed on mute throughout the program. You are welcome to submit questions directly to the presenter following the webinar, and contact information will be displayed at the end of the presentation. In approximately 2 to 3 business days following the webinar, Epstein Becker Green will communicate the availability of the webinar recording and access to the PowerPoint materials. We are pleased to have a fantastic speaker today, Daniel Kim, who is an associate at Epstein Becker Green's Washington, D.C. office. At this time, I would like to turn the webinar over to Daniel.
Thanks, Adam, and I thank you all the participants for joining us today. I hope that today's presentation will be useful, especially to those practitioners who are considering or are just beginning to think about expanding their telehealth practice across state lines, and especially those that are curious about understanding the current landscape regarding the prescribing of medicine through telehealth, or also known as remote prescribing. As many healthcare practitioners in the telehealth industry may know or may have already experienced, telehealth services are only as good as the range of services they can effectively provide. Probably one of the controversies regarding telehealth is whether telehealth services are an effective alternative to certain types of traditional health services, or merely adding cost to the patient as well as the healthcare industry overall. For example, suppose a direct-to-patient virtual care telehealth practitioner had the ability to properly diagnose, but was without the ability to actually prescribe medication as part of that treatment plan. The patient would then most likely have to be referred to a local healthcare practitioner, only to be re-examined, re-diagnosed, and then written prescription. Obviously, this model would be redundant and would most likely create little to no value and add cost to both the patient and perhaps the payer. However, if the telehealth practitioner was able to prescribe medication after reviewing the patient's medical record and performing a full examination according to the standard of care, this model would be effective in providing the patient treatment, add value by increasing access to the healthcare provider or specialist, reduce the time needed to visit the provider, and also enable the patient to conveniently pick up his or her prescription at the nearest pharmacy. So it's not unreasonable to say that the telehealth practitioner's ability to remote prescribe is essential to the telehealth practice. Yet, as we will see today, remote prescribing presents itself as one of the most significant barriers to the wider adoption of telehealth services. So today we will be covering a brief and general overview of current requirements governing remote prescribing. Then we will cover restrictions regarding the prescribing of controlled substances by briefly explaining the Federal Controlled Substance Act and its restrictions on online prescribing, as well as carve-outs made specifically for telemedicine. And then lastly, we will then briefly present on some of the current federal and state legislating efforts in lieu of the opioid crisis. I think many of you have heard in the headlines that may affect remote prescribing. And I just want to note to all the participants today that there shouldn't be confusion between what remote prescribing is with something called e-prescribing, which is simply the issuance of a prescription electronically rather than in the written form. So whether physicians and other qualified healthcare providers may prescribe medication are governed by both federal and state law. However, due to the lack of a federal framework, many of these states are left to work it out themselves. Because these laws vary from state to state, telehealth practitioners and stakeholders that wish to practice across state lines will have to prepare themselves to comply with different and sometimes conflicting laws. To describe each particular state remote prescribing requirements would certainly take more than 15 minutes allotted for today's presentation, so we won't do that. But there are some general requirements that are common across all states, one of which is the licensure requirement. With a few exceptions, each prescribing practitioner is required to maintain a full and unrestricted license in the state where the patient is located, while some states like Indiana, Oregon, and Texas still issue something called a special telehealth license to qualified physicians, which is almost an expedited or sometimes less burdensome licensing approval pathway. The number of states that issue such special licenses are by far and few, thereby not making it a very good option for practitioners seeking to expand their practices nationwide. Besides special telehealth licenses, there are other exceptions or routes by which telehealth practitioners may be able to practice across state lines. For example, some states like South Dakota allow certain practitioners to practice across state lines through licensures by endorsement and reciprocity, meaning that between maybe a couple states, if there's an agreement, a practitioners holding a valid and unrestricted license in a particular state might be able to obtain license practicing in another state. Other states like New York have created exceptions to the licensing process for practitioners who are licensed in bordering or adjacent states, and these are sometimes called quote-unquote bordering state exceptions. In addition to certain state exceptions, there are several interstate compacts where licensing boards and legislatures from different states have agreed to provide expedited pathways to licensures for qualified practitioners. For example, about half of the United States and one U.S. territory are members of something called the Interstate Licensure Medical Compact, which provides an abbreviated licensure approval pathway for qualified physicians. There are also other types of compacts, such as nursing licensure compacts, APR compacts, and APRN compacts, and psychology compacts. Something of interest is that the APRN multi-state licensure allows prescriptive authority to those nurses for non-controlled substances. In addition to being fully licensed in the state where the patient is located, prior to prescribing to patients, all states require professional healthcare providers to establish a patient-practitioner relationship. Again, each state has its own requirements, but some of the common elements seen across the states, many states, in establishing a patient-practitioner relationship through telemedicine is sometimes real-time audio, video technology, verifying the patient identity and location, disclosing and validating the telehealth provider's identity and credentials, complying with the appropriate standard of care, and performing the appropriate physical examination or consultation of the patient. Now, the definition of the latter, what actually constitutes appropriate physical examination, is very highly variable from state to state. While some states used to require in-person physical examinations to establish a patient-practitioner relationship, in 2017, several states actually changed their laws regarding prescribing through telehealth, thereby leaving Delaware as the only state, actually, that explicitly requires physicians to conduct an in-person examination to establish a patient-practitioner relationship. Other states are somewhat vague because they do not explicitly mandate an in-person examination or evaluation. For example, New Jersey's laws, prescribing laws, simply require that the physician perform an appropriate history and physical examination prior to the dispensing of drugs or issuing prescriptions to an individual. However, New Jersey prescribing laws do not describe how those physical examinations should be conducted. Then there are other states like South Carolina that allow physical examinations or evaluations to be performed by other means, often including through instrumentation, diagnostic instruments, or other technologies to accurately diagnose and treat while conforming to the applicable standard of care. Therefore, once a healthcare practitioner obtains a full unrestricted licensure in the state, the patient is located and also establishes a patient-practitioner relationship unless the state provides other specific requirements. Practitioners are most able to prescribe certain medications to the telehealth services. Obviously, I'm going to caveat this by stating that this is a very general and high overview, and those that wish to prescribe in other states should definitely consult their legal counsel. Now, when it comes to prescribing a controlled substance, there's something called the Controlled Substance Act, which governs this practice, which was amended by something called the Ryan-Haight Online Pharmacy Consumer Protection Act of 2008, commonly referred to the Ryan-Haight Act. So this law specifically requires that valid prescriptions be issued for a legitimate medical purpose, and also requires at least a one in-person medical examination of the patient before any controlled substances are remotely prescribed. Obviously, this in-person examination requirement seems to run counter to the idea of telehealth, and is probably one of the main hindrances to the telehealth adoption. But there are several carve-outs. For example, what a covering practitioner, they might not have to do an in-person consultation because as long as they meet the definition of a covering practitioner. Also, Congress created certain exceptions that are specific to telehealth, but as you can see, most of the exceptions wouldn't apply to practitioners who wish to carry out a direct-to-patient virtual care model. But there is one special exception called the Special Telemedicine Registration, which a lot of the telemedicine practitioners and stakeholders are really looking up to. However, since its passing in 2008, the Drug Enforcement Agency, or the DEA, still has not created rules, thereby not making it this special telemedicine registration available to remote prescribers. But there are several states like Idaho and Rhode Island that have aligned themselves with the Ryan-Haight Act by either incorporating the federal law, and then there are also other states who have taken less restrictive approaches by either prohibiting certain drugs or classes of drugs or limiting the prescribing of controlled drugs for certain purposes. For instance, like Texas, they allow the prescribing of controlled substances, but explicitly prohibit prescribing of controlled substances for chronic pain management purposes. I'm not aware of any telehealth practitioners or stakeholders who have taken leeway to prescribe controlled substances without an in-person examination, despite what the language of the state law and regulations may suggest. Again, I'd strongly recommend that practitioners and stakeholders seek legal counsel with their attorneys who are knowledgeable about both the federal and state remote prescribing laws. But as many practitioners and stakeholders in the telehealth practice are aware, the movement to tackle the opioid epidemic, which was declared a national public health emergency by the administration last fall, has spurred many conversations on how telehealth services can effectively contribute to addressing the issue at both the federal and state level. At the federal level, there have been several bills that are specific to opioid, tackling the opioid epidemic, and these pertain to prescribing of certain controlled substances like opioid agonists for patients seeking drug therapy treatments to fight substance use disorders. Of course, this would be narrowly applicable to only behavioral and substance use practitioners. But along with these opioid bills, there has been a resurgence to the DEA, to have the DEA and the General Attorney write rules concerning the special telemedicine registration exception, as seen by the passing of the passing in the House of the Special Registration of Telemedicine Clarification Act of 2018. The opioid crisis has also encouraged state legislation, and but I would caution that not all state laws being passed are useful or effective. For instance, Connecticut just passed a law that would appear to expand remote prescribing of Schedule 2 and 3 controlled substances through a telehealth platform. However, the actual language, if you actually read the language in the bill, really only shows the state's support of fighting opioid substance use disorder through telehealth without actually addressing whether an in-person examination is required prior to prescribing controlled substances or creating exceptions to such requirements. On the other hand, you have a state bill like Michigan that was passed last year, explicitly allowing the prescribing of Schedule 2 through 5 controlled substances after a bona fide prescriber-patient relationship is established, including one that is created through telehealth. But the caveat is that that prescriber must provide a follow-up care to the patient to monitor the efficacy of the prescribed controlled substance in the treatment of that patient's medical condition. So I think I ran out of time, but I thank you again for joining us in this session, and I hope that it was somewhat helpful to you. And if you have any specific questions, feel free to contact me at a later point. Now I'm just going to turn it back to Adam. Thank you.
Great. Well, thank you for joining us. This concludes today's webinar. You're welcome to submit questions directly to today's presenter at dkim@ebglaw.com or via telephone. In approximately 2 to 3 business days following the webinar, Epstein, Becker, Green will communicate the availability of the webinar recording and access to the PowerPoint materials. Additionally, tune in again for the next 2 sessions of this telehealth crash course series on July 17th, discussing the 5 factors to consider when choosing initial and expansion states for your telehealth practice, and July 24th on Telehealth Portal Essentials. Thank you.